and welcome to Beyond the Scales, starting the obesity conversation, where we unravel the complexities of obesity. I'm Emily, and I'm joined by my co-host, Fran.
Hi everyone, we're two medical students on a mission to demystify obesity, as there's so much more to the topic than just a number.
We're honoured to have Consultant Bariatric Surgeon Mr Lee Humphreys working with us on this project. He brings a wealth of clinical expertise to help us navigate this complex condition.
Thank you both for inviting me, and please don't say you're honoured. It's a pleasure.
Today we're going to be having a conversation and almost a debate, aren't we, about is obesity a disease? So, Mr Humphreys or Lee, would you like to start us off?
So I think this is a great question and one that is debated all around the world. I think a lot of countries have now recognised obesity as a chronic disease, but importantly for us, the UK has not. And there may be some good reasons for that. But I think it's interesting to explore this in a little debate and see if we can uncover some of the issues, some of the pros and some of the cons about classifying obesity as a disease, and see where we go from there.
Definitely. I think there's, particularly if you start classifying it as a disease, especially in the UK, then the burden that would have on the NHS and requiring lots of additional resources, which people want anyway, they would have to be able to give that.
But I guess on kind of the other hand, you could argue obesity, there are lots of costs later down the line on the NHS.
Yep.
So there could be a side of it eventually, it could actually be less. I mean, we don't know right now.
That is true.
That is a way to think about it.
Yeah.
So I think you started off with an interesting point there about a concern about labelling obesity as a disease and the implications that might have for the NHS and resources. And that to an extent is true. However, whether we call obesity a disease or not, that doesn't change the number of people living with obesity currently in the UK. So the burden of disease is there. We're just choosing not to call it a disease. Now, how does that help or how does that hinder? So I think an advantage potentially of classifying obesity as a disease is it means that there would be an obligation on the NHS to treat people living with obesity. And there would be some legal obligations around that. And also, if we classify it as a disease, the hope would be that there would be more resources put into not only treating obesity, but also researching and understanding the causes of obesity, which are multifactorial, as we've touched on in another podcast, and I'm sure we'll touch on again in other episodes. But one of the real difficulties around this is, what is a disease? In order to classify something as a disease, you have to define what is a disease. Now that sounds like an easy thing to do, but is it?
No, definitely.
I mean,
definitely not in this topic.
I've heard so many different definitions of a disease, so I think it's which one do you go by?
At GCSE, you're taught that a disease is being free from, like, not being free from health, isn't it?
Yeah.
That's what you write for your 1 mark answer
Yeah.
in your GCSE biology exam. But the question is obviously, and I've seen it on placement, and I'm sure you've seen it as well, Lee, is you can have an obese person that is healthy.
Yeah. Yeah.
So
there's a couple of things there, aren't there? There are several different definitions of diseases, and we don't need to discuss them in detail. And they all have slight variations, and obesity probably fits into most of them, but you can clearly argue that it doesn't get classified as a disease, and some people are arguing that very strongly. One of the factors about what is a disease, when it has to affect form and function of the body in some way. And I think obesity definitely meets that definition. But also, how do we define obesity? So we have to be able to define what's a disease, and then we have to be able to define what is obesity. And clearly there are some very simple things that we use to define obesity: body mass index, BMI, being the most universal and the one that I'm sure most people have heard of. And we classify people as obese when their BMI becomes over 30. Now, you raised the point there, Emily, about people being obese and healthy. What do we mean by obese and healthy?
Well, I think, I don't know about your experience, but some people I've met don't have any kind of current health problems that they're aware of that are kind of impacting them right now, if that makes sense.
Sure. So if we were to tomorrow classify obesity as a disease in the UK and say, right, everybody with a BMI of over 30, you have a disease, there will be a large number of people who will go, well, hold on, actually, there's nothing wrong with me. And we could measure their blood pressure, we could measure their lipids, we could look at whether they've got fatty livers, etc., etc. And actually, there would be a cohort of people who would have none of those things. So BMI alone has flaws. So it's widely used, it's universal, and it's like that because it's easy to measure and it's reproducible. But you can't classify people as having a disease based only on that as a measure. There are other things that we need to look at. So we need to look at blood pressure, we need to look at lipids, we need to look at whether they have metabolic diseases such as type 2 diabetes. So you have to look at each individual and not just rely on BMI. And there is this concept of people being obese and metabolically healthy. And I think that's what you're alluding to, Emily. And there are, as we've already said, patients who are classed as obese but don't have any medical problems. Now, the interesting thing is we're talking about a snapshot in time. So, yes, absolutely, you may be a 20-year-old person with a BMI of 32 and you have no other sequelae of being obese.
Yeah.
What happens in 10 years' time? What happens in 15 years' time? And this, for me, is where the argument about you can be obese and healthy falls down. We know that if you follow people up for long enough, they will develop the markers of metabolic disease that commonly go with obesity. And the longer you follow people up for, the more likely they are. There was a recent study that showed, looking at metabolically healthy obese people, that after 16 years of follow-up, 50% of those people had developed obesity-related disease. So we have to be careful, but my belief very much is that if you are obese, at any one point in time, you may not have markers of obesity-related disease, but we do know that you are significantly more at risk of developing those diseases than someone of the same age, same ethnicity, with a BMI in the non-obese range.
Yeah. Okay. And it's very interesting, isn't it? Especially with that follow-up. But it's also one thing that certainly comes to my mind is it'd be quite a challenge to communicate that to a patient, and especially when they are in that healthy phase, they are in maybe the beginning of obesity and there's nothing wrong with them. And it's, preparing them, and psychologically that can have quite a big impact. Some people, they get empowered from it and they want to change and things like that. And some people, it makes no difference whatsoever. And some people, it goes the complete other way.
And again, so some of the pros and cons of classifying obesity as a disease come in here. So we know that there's stigma against obese people in society, in the media, amongst health professionals.
Yeah.
So one argument for classifying obesity as a disease is that you would help reduce that stigma. By saying it's a disease, people have got a disease, there may be less stigma attached to it. You could, however, have the opposite effect. Some people may find themselves stigmatized when they didn't feel stigmatized before because they didn't think there was anything wrong with them. And you could also give some people anxiety around their health going forward. When they're currently well, as you say, they are then worried about what happens for the future. And my experience and the number of people I see in my clinic is that most people don't come forward to get treatment for their obesity when they're young and they're well, in inverted commas. It's only as they start to develop some of the health problems associated with being obese that they come to seek treatment. And often, for a lot of people, it's the development of type 2 diabetes, because people recognize that that's a serious condition, or can be a serious condition, with a multitude of longer term health effects. And that's the thing that gives people a shock. Right now I'm diabetic. I've really got to do something about this. Whereas until the point they became diabetic, it was, well, actually, it's not really bothering me. I'm not that worried about it. I've always been big. Is it really a problem?
And do you believe that's due to being given that disease diagnosis, that's when they have that moment of...
Yeah, because I think when they're told that they've got type 2 diabetes, people realise that is associated with some very serious health implications. Yeah. And it's a shock to people, and actually now I've got to do something about it. And that happens frequently.
Mm. And how do you think it might change kind of doctors' perspectives? Because as we've spoke about before, some patients might feel stigmatised by doctors just from their experiences. So do you think that would help in a positive way or a negative way?
Again, there are two sides to the argument. My personal feeling is that if it was classified as a disease, I think it would help. I think we would properly educate people around the causes of obesity. And by people, I mean healthcare professionals. One of the reasons we've started this podcast is that we know there's very little actually taught about obesity in medical school. If it was a disease in its own right, you would almost certainly be taught it in your curriculum. So we're not teaching doctors of today about obesity and then how to empathize with patients, how to talk to patients about their obesity in a way that doesn't make patients feel stigmatized and actually offers them help. So I think if we were to classify it as a disease, it may well help that situation. And, there are still a lot of healthcare professionals out there who don't believe obesity is a disease, and they believe it's down to patient choice and lack of willpower. And I think we know that's not true. And classifying it as a disease may help to overcome some of that.
Yeah.
So it is difficult, absolutely.
Yeah, definitely. Yeah, no, we've got it's certainly an interesting topic, and it's certainly a challenge, isn't it, when taking a history or and when speaking to patients and asking about their past medical history and stuff like that and bringing it in.
Yeah, it can be difficult, and we know that lots of doctors don't talk to patients about their weight or about being obese because they're afraid they may offend patients.
Yeah.
And that is a difficult thing. And I think, you have to be in a position where you can have a conversation with a patient about their weight in a sensitive manner. And I think in my experience, and I appreciate that because I'm a bariatric surgeon, I'm seeing people at the end of a journey when they come to me for final treatment. All the patients that walk in through the door of my clinic know they're obese. So having a conversation with them about their obesity is not a difficult thing. And they've all come to see me because they're obese, and they all joke about it. But having the first conversation, broaching that topic, is uncomfortable for lots of people. I think actually if you can tie it in with a health condition, it makes it easier, because as we've just discussed, if you can say to someone, actually, we found out you've developed diabetes and almost certainly this has happened because of your weight. We appreciate that's something you've struggled with all of your life. You've tried many things. We know that this isn't your fault. We recognise that obesity is a disease that leads to complications like type 2 diabetes. But actually what we can do is refer you on to a specialist weight management program where you'll meet a group of experts who can help you with your condition. That's a very different conversation to what's tended to happen in the past, which is, oh, you're type 2 diabetic. Basically, you just need to go away and lose weight. Here's a diet sheet. See you in a year for your diabetic checkup. Those are two very different conversations.
So I've seen the latter happen quite a lot. But it is quite sad, because when that door closes and the patient then leaves the room, the first conversation immediately happens between me and the clinician of, I wish I could offer that patient weight management, or I will refer them for weight management. But the waiting list is so incredibly long that, and it does, so this is all I can offer now is this piece of paper, or here's some websites, or unless they have their own money to fund it themselves, then it's a huge issue.
Yes, there are difficulties, and I'm not going to deny that currently there are very long waiting times to start weight management programs, but that doesn't mean that you shouldn't refer just because there's a long waiting list. If you never refer, the patient's never going to get into the program.
Yeah.
So you should have that referral. That referral should be made. And yes, of course, I appreciate that there's limited advice and help that can be given in primary care, and some support can be given, and that's great. But the first step is to make that referral to a specialist weight management program. But the number of patients who feel that they have to fight to get that referral in the first place, I find unacceptable. There are lots of clinicians who don't refer patients to a weight management program, even when patients meet the criteria. Now, again, why is that? It may be, as you say, because the clinicians feel that the wait's too long, but that doesn't mean that you shouldn't refer. There are still clinicians in this area that don't know we've got a weight management program, despite us having one for over 16 years. And there are doctors who openly admit that they do not believe in bariatric surgery and specialist weight management. So therefore, they will not refer. Now, I think that is a very difficult position to defend, personally, but I have heard of that happening on more than one occasion. And again, that comes back to weight stigma and bias, and a lack of education and a lack of up-to-date knowledge from those clinicians on obesity and the current treatments. So again, comes back to, if we classified obesity as a disease, I think that there would be a requirement for CPD for GPs, and it's not just GPs that we see this from, but for clinicians to keep up to date and educate themselves, and hopefully it would help to stop some of these poor practices that we see. Because we know that if you tell a patient that they're overweight, or they have an obesity-related illness like diabetes or sleep apnea or arthritis, and you say to the patient, well, all you need to do is lose some weight, they will walk out of your clinic room feeling like they've been blamed. It's their fault. They've failed. It's a lack of willpower. And we know for the vast majority of those patients, they will put on weight. They won't lose weight. So you've got to offer people appropriate help. Otherwise, we won't make any progress.
Do you think if it was labelled as a disease in the UK, that those waiting lists and weight management planning and things like that, do you think more spots would open up, or more staff would be recruited, or do you think those waiting lists would go down, or do you think it would make no difference whatsoever? And then because it's labelled as a disease, more people and following training will actually, as they should, be referred for that? Will that then just build and build and build, or?
Yeah, I suspect that if we were to classify obesity as a disease, in the short term, we would see a big increase in demand for our services. Now, we're already overwhelmed in the services that we offer in Tier 3 and Tier 4 bariatric surgery currently. So it would make the situation worse. But if we were to classify it as a disease and there was a legal obligation to treat it, you may well then find that there are targets associated with the treatment of obesity. The NHS loves a target. If you then put financial incentives in place for GPs for treating obesity, you will find that they will refer more people. there will be emphasis put on their treatment. So yes, in the early stage, and this is one of the arguments used on a regular basis for not classifying as a disease, is it will overwhelm the system. I would argue it's already overwhelming the system. It's just being done in a slightly more subtle way. But in the medium to longer term, we are likely to see a reduction in the disease, obesity-related disease burden, a reduction in health spending associated with obesity, getting more people back into work, better for society, better for patients, better for individuals, better for the healthcare economy. But there will undoubtedly be a significant short-term element of financial pain in order to deal with that at the beginning. And that is a problem in the UK, particularly because of the way NHS funding works.
Yeah.
To every ICB or CCG or the people that pay for treatment in your area are constantly worried about balancing their books for the end of the financial year. When we're talking about obesity treatment, we're asking to spend money now to save money 3, 5, 10 years down the line. The NHS funding setup does not work like that. And it's a perverse disincentive to treating obesity. We know in diabetics and bariatric surgery, the financial argument was put to bed over a decade ago. If you do bariatric surgery on a type 2 diabetic, you get your money back in about 3 years, somewhere around that. So it's easy. Now, that financial argument is less clear in non-diabetics. It takes longer, but it's still there. And so we know that it's good value for money, and we know that patients get good outcomes. But one of the reasons we restrict access is because people don't want to pay for those surgeries now to get the money back, in a few years' time.
I think as well, another argument against calling obesity a disease could be, are we over medicalizing things, and could it have negative implications for people if we put a label on them, for work or insurances, things like that?
Yeah, and again, I think this comes down to how you classify obesity. So yeah, you're right, and this is an argument that's going on for ages, that if we call obesity disease, we're medicalizing a problem. I think it is a problem already, but currently the healthcare system and a lot of individuals think that you're obese because it's a failure of willpower. It's your fault. You've eaten your way to that size. You've done it on purpose. You've done this to yourself. If you then medicalize it, what I would argue is we're trying to stop that message, which we know is wrong. Nobody chooses to be obese. Nobody willfully does that to themselves, and we would say, actually, we know this isn't your fault. We understand that there are really complex reasons behind why people get obese, and why when they are obese, it's very difficult for them to keep weight off in the long term, and why now we have new treatments that can help people. And actually, in other countries where there's much more of a private health coverage and insurance base, actually, if you classify as a disease, then you get treatment under your insurance plans. So it would, in some ways, widen access to treatment for people. Currently, I think there's only one private insurance provider in the UK that covers bariatric surgery under their private policies. I don't know what's going to happen with the GLP-1 medications for obesity and private providers at the moment. I'm waiting to hear what's going to happen there. That'll be interesting. I suspect most of them won't cover it because they don't consider it a disease.
That's an interesting point, that they won't cover it, because, going from a different point of view, with the current shortage in so ADHD medication at the minute, that was a lot of effort went into making sure people were diagnosed if they had it and received the correct treatment for that. If we made obesity a disease and then they did require medication, or intervention for what they needed, would we run into the same problem for those patients? Would we have enough medication to supply or not?
Yeah, well, currently there's a massive shortage of the GLP-1 analogues. And there are a multitude of reasons for that. But the companies, particularly Novo Nordisk, who currently Wegovy is the big player, they massively underestimated demand and are investing huge amounts of money in manufacturing to catch up with demand.
But what happens if, say, somebody does lose a significant amount of weight and they're no longer by weight or, by definition, classified as obese? Going back to Fran's point earlier about insurance and the vast volumes of paperwork and other things, that it will be quite life-changing and a burden essentially in order to change that. And then what happens if you, because everyone swings, what happens if you swing back again and develop obesity later?
And that's the argument for needing long-term treatment. We don't know what the position will be in the UK currently. We don't know what happens after this 2 years of semaglutide. The NICE guidelines are quite grey. So some people are saying, well, could you treat patients for 2 years, stop it for a month, and then restart it for another 2 years? We don't know because the guidelines aren't clear. But what we do know is that the majority of people will put back on their weight fairly rapidly after stopping. So, we have to move to an acceptance that this is a lifelong disease that will need, for most people, lifelong treatment. Now, if you have treatment and you come out of the obese range into the non-obese range, should that treatment be withdrawn? Well, no, because the treatment's been successful. It's done what you want it to do. So to then stop it, knowing that the weight is likely to come back on, is perverse, in my view. But that's currently the way we're approaching it. But I think, again, if we accept it's a chronic lifelong disease, then we are likely to have to shift to models of chronic disease management like those we see in hypertension. Hypertension is actually quite a good analogy for obesity treatment, actually.
Yeah.
And that model is something that people are talking about. And we will need multimodal therapies.
And do you think, from your experience, kind of talking to patients, that similarly, I'm coming back to the hypertension, but if people don't want to take the medications, it's not going to help. So do you think by labeling it a disease and getting more kind of treatment out there, do you think patients would be on board to do it?
I think currently patients who want treatment will come forward and be pushing for treatment. They have issues then getting access to that treatment, despite the fact that they want it. I don't think I'm not aware of a large number of people who currently don't want treatment and are not looking for it, but they must be out there, I suppose. And yes, it is possible that if we accept that it's a disease, then that might happen. I mean, the Royal College of Physicians has accepted it as a disease. And I think one of the other upsides of accepting it as a disease is that you then have to link in with public health. And I think there'd be different campaigning around it. And it is a problem that requires a whole system approach. So there's the medical aspect, which we've been talking about. There's the public health aspect. And the public health aspect is really about prevention. We've been really bad at prevention in the UK. Not a single prevention measure has actually worked. And there are lots of arguments about why that may be the case, but overall prevention is currently not working. And even if prevention worked tomorrow, we wouldn't see the impact of that on the population for a decade or two or more in some cases. So prevention is important, but it's different to treatment. They're both interlinked, but they require a different approach. And then, then you'd have the government as well having to look at food companies.
Yeah, so it's a lot of points, isn't there? I think supporting and maybe even a lot of questions need to be answered first prior to, can we call this a disease? We need the public's opinion and what do the patients think.
Patient engagement is really important
Yeah.
for any strategies in the longer term. And there is lots of patient engagement at various levels about what's going on. I think then in countries that have adopted it as a disease, I think they've accepted that there are some difficulties with making obesity a disease, but actually they've taken a pragmatic approach and said, on balance, we think in this country that classifying it as a disease allows us to do more research. It allows us to tackle things at different levels and in different ways. And overall, we feel it has more benefits than it does negatives. And I think that's a very reasonable approach and one personally that I support. We've clearly got to do something differently in the UK because what we're currently doing isn't working.
No. And it's probably quite a good ending note, isn't it, really, to wrap up that conversation. Thank you for listening, and hope you look forward and listen to our next session.